very recently, the standard of care has changed for patients after resection of an early stage non-small cell lung cancer with an EGFR mutation. So first, we have to screen for this EGFR mutation, at least in the non-squamous population, and then Osimertinib, given for 3 years, is now a treatment that is approved in a lot of countries. So one of the questions we have is, in this population, is still platinum-based chemotherapy a mandatory treatment between starting the start of Osimertinib and the surgery? So in this controversy session, I was pro adjuvant chemotherapy, and it's based on a few arguments. First of all, adjuvant chemotherapy is known to cure more patients than surgery alone. It's true in an unselected population for stage 2 and stage 3 based on the 8th TNM classification, but it's also true in the subgroup of patients with EGFR mutation, although the data are rather scarce. Adjuvant chemotherapy seems to bring a benefit both in the wild-type EGFR population, but also in the EGFR-mutated population. It doesn't seem that EGFR mutation will induce resistance to the chemotherapy. Then we also look at the prognosis of EGFR mutation, because we know that the patients with a very good prognosis, like those patients with stage 1, that do not need adjuvant chemotherapy, but the prognosis of EGFR after resection of non-small cell lung cancer is not very different from the other patients. Some studies suggest it's a bit better. Some suggest it's a bit worse with more recurrence. But overall, it's not a population with a special prognosis, a good prognosis that would allow to skip the adjuvant chemotherapy. Then I look at the studies that have compared first-generation TKI and chemotherapy in the adjuvant setting, and these studies overall show the same overall survival, showing that there is clearly a role for the adjuvant chemotherapy. Finally, if you look at the Osimertinib efficacy after chemotherapy, it doesn't seem to decrease the efficacy of Osimertinib versus placebo in the ADAURA study. There are two subgroups that were studies: patients that had surgery and directly Osimertinib or placebo, and patients that had surgery, chemotherapy, and then Osimertinib and placebo. And the magnitude of the benefit of Osimertinib is very similar in these two populations. So now that we are re-examining our frontline option in metastatic patients with EGFR-mutated NSCLC with potentially a TKI and a chemo upfront, let's see the results of FLAURA2 probably this year. I don't think it's time to skip the platinum-based chemotherapy in this population, in particular in the adjuvant setting.